Hey everyone, we are just waiting for more participants to get through the door, and we'll be starting the webinar in just a few moments. Okay. I think we can open the webinar at this point. I want to say hello and welcome everybody who is registered for this webinar and is joining us today. My name is Donna Magoon, and I am the chapter coordinator at APDA's Virginia chapter. Thank you so much for joining us today. I'm pleased to welcome you to the third presentation of our three-part educational webinar series. These webinars are designed for people with Parkinson's disease, as well as their care partners, family members, and healthcare providers. We're very grateful today to Dr. Michael Shapiro for contributing his time to present today's topic, which is cognitive and emotional changes in Parkinson's disease. After some brief announcements, Dr. Shapiro will make his presentation, after which there will be a Q&A session where you'll be able to ask questions about today's topic. Slide. Thank you. American Parkinson Disease Association Virginia chapter, APDA for short, is part of the largest grassroots network dedicated to fighting Parkinson's disease and to helping the more than 1.2 million people with PD in the US who help them live life to the fullest. The APDA Virginia chapter offers a variety of services to our constituents around the Commonwealth. Please visit our website to understand and explore all of the things we have to offer. The website also hosts a wealth of information on publications, webinars, articles, and research updates that can help you understand Parkinson's disease. If you are participating from another state, know that we have chapters and locations all around the United States, and you can find their contact information on our website as well. APDA Virginia can also be reached through our helpline, email, and social media. One noteworthy achievement, which is highlighted on the current slide, I'd like to point out, is APDA Virginia's support in the amount of approximately $3.4 million for PD research in our Commonwealth. We are so grateful for the generosity of our sponsors, which has made this possible. Next slide, please. Please be aware that you can ask your questions at any time during Dr. Shapiro's presentation by typing your question into the Q&A button. There's a bubble at the bottom of your screen in Zoom. He will answer as many questions as time allows during this session. We want to thank our sponsors, of course, Amneal, manufacturers of Rytary, and Kyowa Kirin, manufacturers of Nourians, for generously supporting this program, and to acknowledge their appreciation for the critical need to provide programs like this one. You can visit their websites for more information about their products and services. And now it is my pleasure to introduce Dr. Michael Shapiro. Dr. Shapiro is a board-certified clinical neuropsychologist at Central Virginia's Veteran Administration's healthcare system. He completed his Ph.D. in counseling psychology at Penn State University, followed by a 2-year residency in clinical neuropsychology at Barrow Neurological Institute in Phoenix, Arizona. While there, he assisted in providing care for patients with PD at the Muhammad Ali Parkinson Center. Since that time, he has served as a faculty member at Penn State University, managed private practices in Pennsylvania and Tennessee, and most recently joined the Richmond VA Hospital. His clinical responsibilities primarily focus on evaluating individuals with cognitive concerns related to brain injury, as well as degenerative conditions, including working with staff and patients from the Richmond VA's Parkinson Disease Research Education and Clinical Center, known by their acronym as PADRAC. We are all so thankful to have Dr. Shapiro here with us today. So without further ado, Dr. Shapiro, welcome, and thanks so much for joining us and sharing your expertise on this important aspect of PD.
Absolutely. Thank you, Donna. And I appreciate having the opportunity to even chat with y'all and to provide this talk. Do I have control? I do. Okay. Perfect. So kind of standard fare for some of us physicians, that no disclosures or conflict of interest associated with any of the sponsors of this program. So what are we in store for today? I like to start off with just the neuropsycho what. Most folks have never heard of a neuropsychologist, or perhaps those who have may not understand fully what we're able to do or how we're able to assist. After that, I'll go into a brief overview of Parkinson's, and then some of the psychological symptoms, the cognitive symptoms, as well as treatment options and considerations. So let's see. So clinical neuropsychology, what is it? At the most general sense, I kind of like to explain it to all my patients as, if you look at that picture of the mechanics down at the bottom, we are part of a treatment team that is going to take the brain out for a test drive. So you may have your neurologist, you have your physical therapist, your speech therapists, maybe a lot of physicians that are more interested in understanding how do all the nuts and the bolts and the wires and the structural integrity of the brain, how is that working? And when you get referred to us, we often take the brain out for a test drive, do a status report, and then coordinate with the other team members to implement treatment options. So at kind of a base level, we study the intersection of where the brain and that behavior works out. So we study how the brain functions under ideal situations and how it should function on a day-to-day level, but then also how it functions when insults, injuries, or changes occur. And that could be really anything. So if we think about the way the body, the brain, and then the output, the behavior work together, if you are sleep deprived, the brain is not going to operate optimally. If you're under the influence of alcohol, it's not going to operate optimally. Similarly, if it succumbs to any kind of insult or injury, whether that's a concussion, traumatic brain injury, multiple sclerosis, or in today's talk, Parkinson's disease, there are certain changes that we are going to look for, both in the way the body works, the way the mind works, the emotions work, etc. And really, that's the focus of this talk and a lot of what my bread and butter in my everyday work is. It's evaluating cognitive functioning as well as psychological functioning. So symptoms, severity of symptoms, and the impact on life of each of those domains. So what do we do? If you get referred to us, kind of what to expect. We do a lot of fun things, at least I think they are, but there's no poking, there's no prodding. We don't hook you up to any fancy machines for the most part. It's an in-office visit, often one of the lengthier visits you'll ever be involved with. They can run anywhere from a few hours to 8 hours, depending on the location that you're seeing the person, whether it's a VA, a standard hospital, a private practice. Everybody runs things a little differently, but we basically do a thorough evaluation in terms of an interview, get a great background about who you are, what kind of life factors contributed to where you are today, your education, your job, your mental health history, your medical history related to Parkinson's, but also any other history, whether that's heart disease, whether that's whatever it may be, medications and things like that. And then we're going to sit down and do a bunch of hours of testing. And that's really to look at how do different areas of the brain work. So we'll test out your memory, your speed of thinking, your language abilities, things like that, that we'll kind of chat about in a little bit as well, to look for your patterns of peaks and valleys, your strengths, your weaknesses, and to see how those fit together. Because there's lots of things that are going on in an individual that might impact the way you do on testing. As I mentioned, your sleep, whether you're experiencing depression, whether it's the effects of your medications that you're taking for Parkinson's, or the changes in the brain associated with Parkinson's disease. So that's part of what we do. And the kind of when to seek a referral. I saw that come up in one of the questions earlier as well that got emailed. It's really anytime. You can seek out a referral at the earliest concern of a behavior change. That might be in mood, it might be in temperament, it might be in hallucinations or delusions or other things. But it could also be your spouse or yourself are concerned about changes in the way the brain's working, maybe mentally not feeling as sharp or starting to have memory troubles. There's nothing wrong with seeking out a referral at the earliest point. At the very worst, we get some data on you and you're functioning well. And what we can use that for is then comparison down the road at year 2, at year 5, at year 10, at year 20, and compare apples to apples the best we can over time. It can also be a case where we are seeing symptoms from a cognitive perspective earlier than the formal diagnosis of Parkinson's gets made. And perhaps you've never been to the neurologist yet, and it can be a helpful stepping stone to get there. And then how can we help in a very broad sense? Given that we have the amount of time we do, we are learning a lot about you, your family structure, your support structure. We get to learn a lot about what concerns you have and how they're affecting your life. And it leaves us a lot of room then to evaluate cognitive strengths, weaknesses, and get a better understanding of what recommendations we can make to improve quality of life. And that may be, perhaps you weren't aware of a connection with another service. Maybe it's getting psychiatric care. Maybe it's assisting with communicating some of your symptoms to a neurologist who hasn't had the time because they're just very busy folks. So there's lots of things we can do from the day-to-day care. We're also very involved with things like deep brain stimulation surgeries and assessing for any kind of risk factors that might be involved. And clearly, there are some of us that like to do treatment as well. So that may be therapy, it may be cognitive remediation, and other things that I can talk about towards the end of the presentation. Okay. So as we talk about Parkinson's, I am not going to speak necessarily so much about the entire disease. If you've attended the other two talks, those physicians did wonderful jobs. And so essentially, I think we mostly know that Parkinson's disease is a whole body disorder. You often will hear neurologists and other folks talking about kind of tip the head to toe, anything in between can be affected. The most common symptoms that we're aware of or maybe facing or kind of treating are the physical ones. When we think about, what do we know about Parkinson's? So the tremor, the bradykinesia, the instability, the rigidity, some of the autonomic factors like the bladder dyscontrol, hypotension, possible sexual side effects. Parkinson's can clearly also impact sleep, from REM sleep behavior to sleep apnea to disrupted cycle. Those are slightly outside of my area of expertise. Clearly, I deal with them, but not in a direct way. My focus is really on the things on your right, the cognitive and the psychological. And I mentioned before, memory, attention, language, might be visual spatial abilities, might be problem solving abilities. And then psychological, some of the things that we'll talk about today, the depression, apathy, impulsive disorders, compulsive disorders, and psychosis. So this is a super busy slide, and I only show it not because I want to go down a neuroanatomy pathway where we just get super heady and talk about things about necessarily the interconnections in the brain, but I do like this slide because it highlights the connections that are so close together. I don't know if you can actually see my mouse or not, but generally speaking, when we talk about Parkinson's, it's a disruption of the dopamine pathways in the basal ganglia, which is largely these structures down at the bottom, where you can see that kind of they're connected. And there's the red, there's the green and the blue. And the red is often the symptoms we're most familiar with, again, kind of those physical symptoms of Parkinson's. But you can see in all of these structures that are in the subcortical basal ganglia region, they are connected to these outside regions. So kind of if you took your fist and balled it up, your fingers inside would be these kind of subcortical features. And then the outside is more of what we call the cortical areas. And so that motor and the sensory functioning is those red areas. And you can see how closely tied in these tiny structures in the subcortical region of the brain, the putamen, the caudate, and the globus pallidus. They also are very important for what we call frontal systems, which are some of our cognitive, the frontal lobe. You hear that talked about a lot, and I'll be talking about it in a moment as I get into the cognitive pieces. And then the blue being right in there as well with the limbic system, and the limbic being very important for emotional regulation and kind of our autonomic systems as well. And these tiny structures and nuclei in the brain, you can see how it's almost like threading a needle in terms of the closeness and the closeness of the or proximity to each other, and then the networks in which they are able to impact. And once we start to have degrading of the dopamine pathways in one region, it's interconnected. And it's almost as though you're talking about, I don't know, wires in your house. And if you have your cable wires, your power wires, your internet wires, and if you start to fray the wires in one region, it's likely going to have a downstream of impact. So as we start to see the symptoms become greater for the physical, that is also likely going to be associated with other physical, cognitive, emotional symptoms that are prone to being impacted as well. And so I'm really going to leave this slide behind, but I just really wanted to put it out there to show the interconnectivity in the network syndrome that we kind of think of when we think about Parkinson's, about potential features that could all be impacted. Oops. So psychological symptoms, I put those first, mainly because in some ways they're, I don't want to say more important because I don't want to tell anybody what is the most important thing to them, but there's a decent amount of literature that suggests that psychological symptoms are actually more impactful on quality of life than some of the physical symptoms. That people are able to cope with physical changes in their life, but it's the emotional impact that makes it more difficult to then fully live to their fullest quality of life. So one of the problems with Parkinson's is that the psychological symptoms can both be a function of changes neurologically to the brain and the associated neurotransmitters and chemicals like dopamine and serotonin and things like that. But it can also be a reaction to the changes in the body and the way the body is working. So it's both a product of the disorder itself, as well as the response to this disorder. And sometimes that can be very difficult to flesh apart and kind of pick out which one's the cause of the other. But it can also be due to not fully understanding yourself of what is this caused by. And I work with a lot of veterans, and I've seen it in private practice too, folks who have never been depressed before, or their expectations of what depression and anxiety mean. And then if they have the Parkinson's, not really understanding what is what, and why do I treat it, or how do I treat it. And so generally speaking, when we think about Parkinson's, one of the primary psychological symptoms that folks can experience is depression. And there's some estimates that up to 50% of individuals with Parkinson's experience depression at some point in their disorder, and some point after diagnosis. And that can really range. There's a spectrum of symptoms that people can experience, anything from low mood to suicidal thoughts and being severely depressed. And so I work with a lot of folks who have very little experience in their lives with depression beforehand. And they tell me, Doc, what are you talking about? I'm not depressed. I'm not suicidal. I'm not sitting in a dark room. I can get out of bed. And that's great. That is certainly one description of depression, of severe depression. But it's important to recognize that depression exists on a spectrum. So having low mood, reduced interest in activities, more fatigue, feeling hopeless, having changes in your appetite, having slowness in your physical functioning. And I'm sure as I'm saying some of these physical ones, you might be imagining, wait, but those are also symptoms of my Parkinson's. So is this depression or is it Parkinson's? And it's a great question. And it's something that it's helpful to go to a psychologist or go to your neurologist and discuss having those symptoms and getting some help with. But depression can also impact the way our brain works. And even in individuals without Parkinson's, depression can lead to difficulties with paying attention and concentrating, just feeling lethargic and the brain foggy, so slowness of thinking, and having some memory difficulties. The profiles will look very different, but an individual with Parkinson's and an individual with Parkinson's with depression, it can compound those difficulties. Apathy's up there as well, and that's often a common symptom with Parkinson's as well, a unique feature of the disease, because it's also affecting brain regions that are also important for motivation. And so it's tough sometimes even for me to describe to patients that difference between apathy and depression. But the best way I try to conceptualize it is a lack of motivation to engage in activity, a decreased amount of just activation or caring. Just, they don't really care that I have a new symptom. So not being bothered by things as much. And it could just be slowness to initiate movements as well. Anxiety is another one where we have a continuum. So when folks say, what do you mean, do I have anxiety? It can be difficult. Is it worry? Sure, to a degree. Anxiety is worry, but we usually classify it as excessive amount of worry, or worry that is present more often throughout most days than not. So out of a given week, we are going to say that, yes, you experience excessive amounts of worry or rumination, kind of that hamster wheel that you can't get off of, kind of getting stuck on a thought. And that's present for the majority of the day, more days than not. But that can also be a much wider array of symptoms. And I have down here where we can have phobias, there can be restlessness, there can be avoidance, and there can be panic. And so with individuals with Parkinson's, it's not uncommon and a pretty normal reaction in life to say, I am experiencing physical symptoms that impact my ability to walk or to maybe navigate stairs. And so when I go out to a restaurant, perhaps I feel more self-conscious. I didn't have this before. And during that adjustment period, some people can become self-conscious. However, with anxiety, that can become a constant reaffirming loop. So perhaps the person gets so anxious, they don't want to go out to restaurants anymore and they want to stay home. And then that can snowball of, I don't want to go outside. And it becomes this fearful, well, I'm safe, I feel safe inside because I don't have this anxiety. So it can lead to avoidance and even agoraphobia and things like that. It can also lead to panic attacks if I start to feel panic and terror at the thought of going outside. Again, this isn't what everybody will experience, but to some degree, even that excessive worry at the low end to some of these more severe things, it's estimated about 50% of folks with Parkinson's at some point will experience a degree of anxiety after diagnosis. Now, there was a question that came through earlier, so I hope this answers it, but if not, I will try to go a little bit further during the Q&A. But impulse and control disorders. So in Parkinson's, things that we can see associated with dysregulation of dopamine is these compulsive pathological gambling, excessive buying or shopping, eating disorders of eating too much, obsessing about medication dosing and just really being fixated on when that next dose is going to come, and engaging in repetitive behaviors. And we call this either punding, or we also call it hobbyism, in which people just engage in kind of smaller behaviors throughout the day. That might be humming, it might be writing, it might be tapping, it might be taking things apart. And the problem here is that they can often be associated with some of your medications that you're taking, the dopamine agonists. And so it's important, if you're experiencing these, to chat with your doctor, neurologist, or neuropsychologist. We on my end have difficulty treating this often because it's embarrassing to have to admit to. And so being open and honest with your providers, it's important to be able to kind of identify this so that we can help to treat, because sometimes it's as simple as adjusting a medication dose. So how does a grief fit into the equation with depression? Depends. I guess I'm going to come back to that because I'm going to try to ask somebody to come back, because grief can be a lot of different things. It can be a grief reaction to loss, but grief can also be associated with loss of function. So that kind of theoretical or functional loss versus loss of a loved one, which can be a normal continuum of depression, grief being defined by time limited. When it extends beyond a normal time, we usually about 6 months to a year, we start to consider that to be a depressive episode, which would fit into the treatment options I'll talk about at the end. And so other symptoms of psychological factors is psychosis. And that's a very scary or big word that we use just to kind of talk about hallucinations, delusions, and misidentification syndromes. So with Parkinson's, it could be common to have illusions or misperceptions, perhaps seeing a face in a tree or an image of a person that's part of your wallpaper. So misperceptions. Folks can have passage or presence hallucinations. I feel like there's someone in the room, or I just saw someone walk by in my periphery. Or it could be well-formed objects, animals, people outside, things like that. And delusional thinking, although less common, spousal jealousy, spousal infidelity, having paranoia. And then less frequently than that is misidentification syndromes. These things often occur within the context of dementia, but feeling or believing that a person has been replaced by somebody else, or that two people in the room are really the same person, but disguised. Again, these are less common. And so those are some of the major psychological symptoms that can be associated with Parkinson's. And so cognitive is going to be the next portion of this talk, where I am sure, because I hear it every single day, that either you or your spouse or a loved one has heard these things come out of the mouth. I can't seem to focus on anything. I'm losing my train of thought. I can't remember where I put my glasses. Why'd I come into the kitchen again? Or I don't remember you telling me that. All these things are, to varying degrees, descriptions of difficulties with attention, difficulties with memory, different kinds of memory, or in the drifting while driving, things like visual spatial abilities. And so these are all of the domains that can be impacted by Parkinson's. So I'm also trying to read the Q&As as they come in. A dopamine agonist is a medication we're giving you, something like the Siminet, the carbidopa, levodopa, things that stimulate your dopamine levels. Okay, so cognitive domains that are impacted by Parkinson's. We have attention, we have working memory. These are things like your ability to concentrate on what you're doing. Or if I give you a phone number and you go to write it down, it's not yet your memory yet, but it's what we call kind of that working memory, long enough to keep it online to write it down. The speed of thinking with Parkinson's can often be reduced, both because of your physical slowness, but also just the ability to think as rapidly as you used to. Language abilities, things like coming up with the words that you want to say, thinking of the names of objects or misnaming things. We call executive functions. It's really the frontal lobes of the brain playing maestro to all the other abilities. We often describe this as problem solving, the ability to see things from multiple angles or multiple perspectives, quickly organizing new information, can be associated with aspects of our learning process and with memory, which is the next thing, and our spatial abilities. So all of these things can be affected with Parkinson's disease and to differing abilities. We're going to talk about how in a minute, but these are also a continuum in terms of the change. And so I have the flipped traffic light. I know that's not how the traffic light usually looks. Usually red's up top, green's down below. But I kind of describe this to my patients. At the green stage, everything's kind of good. There might be subtle changes in the brain, and these may predate even the motor symptoms or even a formal diagnosis of Parkinson's. Most often, these are subtle changes with the ability to name words or coming up with the words that you want to say. We call it word finding difficulties. Usually, these might not even cause any problems in your life. Some attention difficulties. You may have heard these next two things. One of them is called mild neurocognitive disorder. The other is called major neurocognitive disorder. These are a lot of words to say for the major, dementia. The middle one is kind of what I call the yellow light. It's called mild cognitive impairment, mild neurocognitive. This is when there are changes in some sort of abilities, whether that's attention, language, memory, whatever it may be. But when I bring you in and test, it's lower than what your baseline was, what it was 10 years ago at your prime. But it's not affecting your day-to-day, what we call functional abilities. So there's no impairments in your ability to manage a checkbook or manage your medications or continue to drive. We usually kind of consider this to be a caution period because it is a decline and it is representing change in the brain. Now, on average, by statistics, and it can be very messy, and I'll talk about that on the next slide, 10% conversion from MCI to dementia each year you continue living. And there's a huge asterisk around that, and I'll get to that in a second. But the last one is the one that usually folks become worried about. It's dementia. And there are grades of dementia from mild to severe. But dementia in my world means we see decline in cognitive abilities that we've talked about, but also now it's affecting your day-to-day functional abilities. So no longer are you able to manage the checkbook or the medications, even with all those tips and tricks you might be using, is no longer effective. And dementia is an umbrella term, and there's dementia due to Parkinson's, due to Lewy bodies, due to Alzheimer's, there's about 10 different dementia possibilities. And so due to Parkinson's disease is one of the possibilities. So what should you expect? The data varies, but estimates generally suggest that about 30% of newly diagnosed people will have some level of cognitive difficulties compared to where they were at their prime. And that 25 to 50% of people will experience cognitive impairment, period. So there's a solid chance at 50% that most folks will experience some cognitive deficits. Now, not everybody with Parkinson's will develop dementia. So there are a lot of factors that kind of make this to be very difficult to use these 25 to 50, or even estimate what percent of people with Parkinson's will get dementia, because there's a very wide range of onset. There's also the different presentations in which people come to us. Some people come and their first symptom is a tremor in their hand. Other people present with no tremor, which is then indicative of what regions of the brain are actually being impacted by your Parkinson's. And then there's other issues like our vascular issues, our diabetes. And when I say vascular, things like heart issues, COPD, hypertension, then diabetes, thyroid issues, and sleep disturbances. These things can also make our diagnosis less than straightforward. And as we get into our 60s, 70s, mid 70s, even 80s, the likelihood that you have other medical factors that could be contributing make it a less than clean picture of saying Parkinson's is the reason you're having cognitive difficulties. And then, of course, psychological well-being for the individuals who are diagnosed. And then there's some evidence that we have, and I wasn't sure how deep to go into this during this talk, but that there might be two different sets of symptom pairing or clustering that we see. One with a more younger onset, perhaps in our 50s and 60s or even younger, that have this frontal, so more of the frontal lobe, and executive, so more difficulties with problem solving or their complex attention of being able to hold a lot of things in mind at the same time. And that these folks present more with a tremor onset and have more bradykinesia. And it's possible that this set of people are less likely to convert to a dementia. And then there's some, again, research. This isn't guaranteed that if you did have a later onset or a later in life diagnosis of Parkinson's, or if you have a longer duration of the disease, that there might be more of a posterior brain region involvement. And that this type of brain involvement really impacts more of your memory and the spatial difficulties at onset. And less than the tremor, you have more postural instability and gait issues. And these folks may have a higher risk of dementia. And their motor symptoms may have a lower response rate to medications. So I really hate to talk about all the things that can go wrong with Parkinson's without talking about the things that could go well or how to help mediate some of those. So as with anything, and I don't care if it's Parkinson's, if it's Alzheimer's, or if it's just an individual who's struggling without a disorder, we want to live a healthy lifestyle. It's more than well known that the heart health is body health, is brain health. So if you have out of control blood pressure or out of control diabetes, that is going to impact the brain. And it's going to be an additive factor on top of the Parkinson's that you may also be having and struggling with. So whatever we can be doing to have good body and heart health is going to help the brain. So exercising, eating a balanced diet. Now on the flip side, there is no special kind of panacea cure-all. If you eat blueberries, it's going to cure you. Eating a balanced, healthy diet is really what we've settled on. The Mediterranean diets are certainly helpful and things like that, but there's no food that wards off all disease. So being sure we manage our weight, diabetes, and if you have sleep apnea, please use your CPAP, and limiting use of substances and substance abuse, clearly. There's a significant amount of evidence that suggests that being socially and cognitively active helps to ward off or prolong cognitive well-being. And so in that sense, using your brain, getting outside, doing some physical exercise, but also being social with folks and maintaining relationships. If you're going to watch TV during the day, try to include some cognitively engaging activities. Maybe watch Jeopardy, maybe try a crossword puzzle, maybe just try to do something that challenges your brain every day. There's no set activity. It's not as though crossword puzzles are going to keep your brain healthy. It's whatever at your level and your interest is going to be engaging and possibly a bit of a struggle. And then there's potential for cognitive rehabilitation and remediation, maintenance. And so some of my colleagues definitely do this. Speech therapy can do a little bit of this in terms of trying to identify what are your cognitive strengths and working with those rather than trying to focus on some of the negatives. And then if we're looking for actual treatments, things for psychological symptoms, this is nothing shattering or new or actually unique to Parkinson's. Depression and anxiety is often responsive to SSRIs, that's selective serotonin reuptake inhibitor. A lot of different words to say we are trying to target serotonin and increase the availability to your brain. And there is no special medication that is the best cure for depression. It's often what is the best for your biochemistry. And sometimes it can be a trial and error, which means you may have to try a drug, maybe have some negative side effects like some GI issues, or you just don't like it, and then you try a different one. I'm not a psychiatrist, so I'm not about to tell you which ones you should or should not be taking. Also for anxiety, they have a class called SNRIs, so that it impacts serotonin, norepinephrine, more of an anxiety and stimulating drug that helps to kind of manage both the anxiety, the up kind of regulation of anxiety, as well as the down from depression. A class of drugs that we call benzodiazepines or anxiolytics, and those might be things like your Xanaxes. We also have non-medication treatment like TMS, which is more of a magnetic stimulation, kind of you wear a halo and other things like that. I won't go into kind of electroconvulsive therapies and because there's other concerns that we may have with Parkinson's, especially if you're considering DBS and stuff like that. With psychosis, we often stick to our antipsychotics. However, I'm also not going to kind of try to dig too deep into this area. One of the problems with a lot of the typical medications for psychosis is that they stimulate dopamine. And if we flood the brain with dopamine, reduce the amount of dopamine in order to stop hallucinations, what we end up doing is impacting your physical symptoms of Parkinson's and making them worse. So we have to often find medications like Seroquel that don't work on the dopamine system as much. And then, of course, as a psychologist, my plug is always for psychotherapy, whether that be individual, group, in terms of getting support from other individuals who also may have Parkinson's or other medical disorders that they're coping with, and family therapy, because clearly Parkinson's is not just a disorder that affects the individual, it may affect the family too. If you're depressed, it's going to affect the way your spouse is. If your spouse is helping to provide some sort of level of care, that might impact too. But generally speaking, anytime a person is depressed, it can affect the entire system. So it's never a bad thing to try to get family involved as well. And then for cognitive decline, there are not a lot of great medication options for this. Most are really reserved until we hit that dementia range or are approaching it. Some neurologists may opt to initiate some of these medications, especially things like the memory medications like Aricept, at the first sign of cognitive impairment. There's not a ton of evidence that really supports doing that, or that it's going to necessarily provide any significant benefit. The one medication class that folks might try earlier, and this is individual to you and between the relationship with your doctor, is an SNRI, amoxetine, which is the generic for Strattera, which is an ADHD drug. And it can often help to increase your attention and your ability to stay focused, which can then possibly help your memory or can possibly help you to be more effective and clear in your thinking. It's not going to improve your memory. It's not going to be a cure-all. It might just help for a time to increase those processes. But I do list a couple of the medications that are frequently used with individuals who are developing dementia. Exelon is one that, at least in the Parkinson's research, has shown to have some positive impact on global cognition. And that really means that once somebody is relatively impaired and having significant struggles in their day-to-day life, it could boost them up a little bit or make them more aware and help them to be able to complete some of their activities of daily living, like bathing, dressing, and just be more present. But again, these are not things that will cure. They are more kind of stop gaps over time. I do believe, oops, that was the end of the presentation. I know I flew through a lot and had a lot of information to go over, and I do apologize for the speed, but I am happy to try to answer any questions that folks have.
Okay, this is Donna again. Thank you so much, Dr. Shapiro. If you have questions, you can type them into the Q&A section at the bottom of your screen and hit submit. Dr. Shapiro will answer as many questions as he can in the time available. And if we don't get to a question, we'll do our best to get back to you by email after the program.
Okay, so I'm also trying to open up to see some of these other ones. Let's see. Okay, somebody had asked about diminished spatial abilities. So driving a car certainly can be impacted. So as we have the parietal lobe getting involved, it can be something as your doctor may have had you try to draw a clock, and you'll start to notice as those spatial abilities become diminished, the spacing of the numbers become distorted, or the ability to draw a circle becomes distorted. So it can really vary. At the most extreme, individuals having difficulty just being able to judge distance between two things, or the spatial nearness, farness, arrangement, depth perception, and other things like that, which can really impact, yes, driving abilities, but even may impact knocking over glasses in the home or bumping into things that are not related to the physical symptoms. So I hope that answers that question. And it again is along a continuum. Let's see, someone was asking about the difference between Alzheimer's and Parkinson's. That becomes a little bit easier for us in some of the earlier stages. Individuals with Alzheimer's rarely have the physical symptoms associated with Parkinson's, tremor, and things like that. And when folks come in to do our testing, there are very specific profiles that we are looking for. Memory is often a really great one for us to help differentiate, whereas in the Alzheimer's group, what we consider to be an impairment is they often have a flat learning curve. So for example, if I read them a list of words and there's, I don't know, let's just say 10 words, the learning curve is flat. So it might be 5, 5, 5, 5, maybe 6 across all the trials. And then when we go to a recall later in the day or later in the appointment, the person often will say, you read me a list of words when I ask them to recall it. And then I might try to have them pick them out of a lineup or something like that and say, was this word on there? Was this word on there? And their answers are incorrect to the majority of those, showing an inability to even recognize the information later on. So it's what we call a pattern of poor or inefficient learning with rapid forgetting of information and poor ability to distinguish or recognize it later. Whereas folks with Parkinson's, more of a classic pattern is a pattern of more efficient learning, but still maybe not to the degree that they are used to. So the list might be 5, 6, 6, 8, 8 or 9. And then they do show the difficulty spontaneously recalling the information as well. So it might be they only get 1 or 2 words. But the real difference is this strong ability to continue recognizing that information. So they might get all of them right on that recognition trial, showing that the information's still in there, but those frontal executive processes that help to go get it, like almost like that claw game, is not functioning right. It needs a little help. So it can't go in there and grab the toy or grab the memory or the information cleanly. It needs the assistance. And that's something we often see with Parkinson's, more so than the Alzheimer's folks. Okay, lots of questions. Wordle's great. I don't have any specific exercises. I do believe that anything that is going to continue to pose a challenge to you is a wonderful task. And the reason I don't have any specific is because I see folks at all levels of what I call premorbid continuum. So there might be an individual who had a learning disability growing up and can't read. Well, I'm not going to tell them to go take a word search or to do Wordle if their vocabulary is not strong, and that's going to be more frustrating to them, and they're likely to just give up on it or maybe get frustrated with it. No. I want you to find something that's helpful for you, that you find it both enjoyable, but also a little bit of a struggle. That could be playing games with your family. It could be Pictionary. It could be something that's just going to make you think. It could be quizzing. You could go to a museum if you like those and learn about something new. There's really sky's the limit, and it's just remaining cognitively engaged and active versus potentially just sitting on the couch and watching what I would consider quote unquote mindless TV, maybe just reality TV for 20 hours a day. Let's see. So yes, so someone asked, is there a self-awareness of cognitive decline, or is family member more likely to identify the changes? And I'd say both. Individuals with Parkinson's typically have a very good insight into their decline. Sometimes it can be subtle though, and you may start to hear spouses saying, sweetheart, I told you that already, or we already talked about this. No, we have the appointment. Remember, I told you. So usually folks will notice that things are becoming more difficult to them, or they might just notice that their spouse is also, or family member is saying something along that. So I do want to say that most folks with Parkinson's have good insight, but as impairments become more progressed, they can be less able to identify them. Somebody asked about, what did I call the repetitive behaviors like humming? I don't know if it's formal terminology. It's punding, P-U-N-D-I-N-G. I think it's a British word. And then the other repetitive behavior is what we call hobbyism. Can I talk about it? Let's see. What are the effects of Zoloft and other antidepressants on cognitive functioning? Usually very little. We usually consider them to be improving cognitive functioning, but I want to say that with a huge asterisk, in that if we're able to remediate symptoms of anxiety or depression, that is going to lead to better ability to concentrate and pay attention, which may then also just be perceived as I am feeling more cognitively acute or on top of it. So they don't actually improve cognitive ability in and of themselves. It's more of a byproduct of depression was causing these kind of dampening of those abilities. And by removing up at least a portion of the depression, we free up some of the cognitive battery is how I describe it to folks. Can I comment on the use of THC for anxiety relief? It's a hot topic. So it really depends on, will it work? Sure, for some people. THC, depending on how you consume it, can also, for some people, increase anxiety or cause them to have panic symptoms. It also is a dual-edged sword where it might cure your anxiety, but we also know that THC has impact on abilities like attention and memory processes while under the influence. So if you're also concerned about your memory and your thinking skills at that point in time, it might not be the best cure or treatment because you might be adding new problems. Similar to use of benzodiazepines, things like Xanax for treatment of anxiety. As we get into aging populations, we found that those types of drugs can actually have a negative effect on memory and the ability, basically can lead to potentially higher rates of dementia due to changes in the acetylcholine and other neurotransmitters. So as folks get older, we really try to take them off of that class of drugs as much as possible. And we seek to use SSRIs and SNRIs to treat anxiety and depression instead. So somebody did ask that, is clonazepam considered a benzodiazepine? And the answer is yes. The neurologist prescribes it to take at night because it addresses REM behavior sleep disorder and also helps to manage with sleep. Yes, and so it's one of those dual-edged swords of, do we want to get better sleep and be able to sleep? Or do we want to potentially take a medication that could impact cognitive ability? And it really is, it's a personal thing that you need to decide amongst yourselves and with your doctors and be assessing risks at all ages. At a younger age, it may have less impact. At an older age, it increases risk, but it's not a guarantee that it's going to cause dementia. And so it's like dealing with the folks that I work with pain and who are on pain medications. What's going to be the best and most optimal? Do we want to control your pain and have you higher quality of life, but it may interfere with your cognitive abilities, or take you off all those meds, think really clearly, but because you're in so much pain, you don't function well. And so all medications end up being like that when we're talking about pain medications, anxiety medications, and things like that.
All right, Dr. Shapiro, I think we have time for one more question.
Okay. I think somebody had asked in the other one, how to decide if you need to see a social worker, a neuropsychologist, or a psychiatrist. Tactics to convince my husband that he needs to go to one. I'm never a big fan of trying to trick anybody into going to see a provider, but you can possibly go see a neuropsychologist as we are the jack of all trades and can help with referrals. And it can be sold a lot of different ways of getting baseline data to make sure we track your abilities over time. And while you're in that appointment, we are going to assess trauma, emotional functioning, and things like that, and can then help to maybe pave a pathway to get to a psychiatrist or to lay the groundwork of the benefits of these medications. Given that I'm a PhD, I don't have the ability to prescribe. So I can kind of talk and make it sound like, hey, this is just something to explore. We can chat about it. It's totally up to you. Here are your options. Here are the potential benefits. Why don't you sit down with your partner, your family, and mull it over? So I do apologize. I know there's other questions, and I am happy to try to answer these via email or any other way that I can. All right. But thank you, folks. I appreciate all the questions and this opportunity.
Okay, and as we said earlier, prior to the presentation, if we don't get to your questions, you can send them to us at APDA and we will forward them to Dr. Shapiro. And I know he'll do the best he can to reach out to you with answers. You can visit our website. There is the information to be in touch with us. This APDA Virginia the email address is my personal email address, so please feel free to direct questions there. and I will forward them on to the doctor. Next slide, please. All right, and now first of all, I want to thank Dr. Shapiro tremendously for joining us today and for sharing his valuable information. That was a chock full period of time, and thank you so much. And many thanks to everyone participating in today's discussion. There were excellent questions and more to come, I'm sure. And I hope everyone has gained some great insights and learned some very valuable facts about the psychological aspects of PD. If you have any additional questions or would like to speak to someone from our chapter, I encourage you to visit our website, email us, or call us, and all of the contact information is readily available. And now I have a few announcements. I want to remind everyone that April is Parkinson's Awareness Month, and that April 11th is International Parkinson's Awareness Day. At APDA in Virginia and our chapters across the country, we're planning a few things to raise awareness and understanding about PD, particularly to the general population. So stay tuned for more details on that. And it is indeed my pleasure to tell you that registration is open now for our live and in-person 2022 Optimism Walk, which will take place on June 25th at Mount Trashmore Park in Virginia Beach. We have not, due to the COVID crisis, been able to have a live and in-person event since 2019. And we are looking forward to seeing everybody face to face again. Again, you can visit our website for more information on the details about the Optimism Walk. And remember to check out the APDA symptom tracker to help you and your loved ones track your PD symptoms. The symptom tracker is available in both English and Spanish, and it can be downloaded from the App Store or Google Play. On behalf of the entire APDA Virginia chapter, we thank Dr. Michael Shapiro, all today's participants, and our sponsors, Amneal Pharmaceuticals and Kiowa Kirin, for supporting this program. If you know someone who missed today's program, if you joined late, or if you would just like to watch it again, a recording of this presentation will be posted to our website next week. It has been our pleasure to offer the APDA Virginia Educational Webinar Series this winter. This is our last webinar in this series, but additional educational programs are always ongoing at APDA. You can check our website and request our bi-weekly e-newsletter to stay informed about all that's going on at APDA. Again, thank you all for your participation today, and we hope you have a wonderful weekend. Thank you.